All right, so it's 7 o'clock. I want to welcome everyone to the ASSFN webinar. First of all, we want to thank the mentors, a big thanks to them for participating in this event. We have a fantastic panel today. We'll start with Dr. Brian Coppell, followed by Dr. Guy McCann, and then finally end with Dr. Jonathan Miller. What I want to do first is I want to have brief introductions. So I'll say the name, and if you could say your full name and what you do and where you are at, so that we can quickly go through all the people who are present in the webinar. So we'll start with Max. Max, are you able to hear us?
He is in the library,
like Max.
He can't talk.
Okay, you can't talk, okay. So next is Brian. Brian.
I'm Brian Coppell. I'm a functional neurosurgeon from Mount Sinai in New York City.
Great. Then we have Dr. Rushna Ali. Dr. Ali, can you hear us? Looks like
his mic's off too.
Okay, mic off. Okay, very good. Then the next one is Dr. McCann.
Yeah, hi, I'm Guy McCann. I do stereotactic functional and tumor surgery here at Columbia.
Okay, good. Next one is Ranjit.
Hi, I'm Ranjit Ganguly. I'm a resident at Ohio State, fourth-year resident. I'm doing my enfolded fellowship this year, so some focus time and function with Dr. Krishna.
Great. Pratik. Looks like Pratik doesn't have a speaker. Tim.
Hi, I'm a clinical fellow here at UBC, Vancouver, Canada, with Professor Chris Honey. We stay here for 1 year.
Great. Next is Atar.
Hi, everyone. My name is Atar Malik. I'm a PGY5 neurosurgery resident at Massachusetts General Hospital, interested in pursuing functional and epilepsy.
Awesome. All right. If I haven't said your name, if you can introduce yourself, if you have the ability to do that, that'll be great. If not, then we'll move on to the next. Okay. So before we start, I would say if you don't have a question, it'll be best to mute your speaker so that we don't have interruption in the webinar. We'll start with Dr. Coppell. He has expertise in psychiatric surgeries, and he's going to talk about obsessive compulsive disorder to ablate or neuromodulate. Dr. Coppell, your answer.
All right, thank you. Yeah, so today we're going to talk about approaching obsessive compulsive disorder, either from a lesional perspective or using deep brain stimulation. Next slide. So, this slide kind of shows the timeline of surgery for psychiatric disorders, literally starting in the late 20s when John Fulton discovered the role of the frontal lobe in psychiatric phenomenon, and then rapidly progressing to the first frontal leucotomy, which is essentially the precursor to the lobotomy in 1935 by Egaz Moniz. And then by the mid-20th century, we are in the stereotactic era, which is essentially the first modern era of psychiatric surgery, which extended into the early 70s when medications kind of took hold and a lot of negative press around psychiatric and surgical interventions for psychiatric disease sort of manifested in themselves. People sort of know popularly the One Flew Over the Cuckoo's Nest, which showed psychiatric surgery in a bad light. And then as DBS began to take hold in the late 90s, we once again see surgery for psychiatric disorders taking front and center in the academic neurosurgical world. Next slide. So these are the classic stereotactic lesions of the modern era. The first is the so-called anterior capsulotomy lesions within the anterior limb of the internal capsule. And this was developed first in 1949 by Lars Leksell in Sweden and Jean Tallerac in France. The subcaudate tractotomy, which is a lesion in the substantia innominata, just below the caudate in the septal type regions by Jeffrey Knight in 1965. Cingulotomy was developed by the classic neurosurgeon H. Thomas Ballantyne of Mass General Hospital in 1967. And then two neurosurgeons in England, two doctors in England, a psychiatrist by the name of Kelly and Alan Richardson, the neurosurgeon in England, developed the limbic leucotomy, which is essentially a cingulotomy in addition to a subcaudate tractotomy, because why not? Two lesions are better than one. Next. And this is a midline picture showing all of the lesional areas all at once. And while they're not completely in the same plane, they roughly are. And it sort of demonstrates how all of these lesions cluster around the cingulate bundle, which is very relevant to the anatomy. Next slide. So, because we're going to be talking about deep brain stimulation, the most important lesion that we need to talk about is the anterior capsulotomy. And as I said earlier, this was developed in 1949 first by Jean Tallerac in Paris, who used stereotactic radiofrequency thermocoagulation. And what they noted with their initial results was that psychotic features were not very affected by the lesion, but that OCD and anxiety, especially OCD, yielded good results. Separately and completely in parallel, Lars Leksell in Sweden at the same year developed a similar lesion using radiofrequency in the anterior capsule. Lars Leksell then went on to modernize this and presented this in a World Congress in 1951 by using stereotactic radiosurgery for this lesion. And that began the stereotactic radiosurgery era as well. Next slide. If you look at the sort of literature on anterior capsulotomy, you can kind of sort of break up the literature in sort of two cohorts. Sort of the ones that are reviewed from the 90s to present, and then essentially from the 60s, 70s, and 80s. And in the 60s, 70s, and 80s, you have to be very careful because the diagnostic criteria for OCD was different, and the rating scales essentially were very, very different. They were much more standardized from the 90s on with the Y-box scale, et cetera. But that being said, one good example of the literature from the earlier cohort shows approximately about a 51% response rate of anterior capsulotomy for OCD. Now again, what response meant in that era is a little unclear. In this era, we define that as a greater than or equal to 35% reduction in the Yale-Brown Obsessive Compulsive Scale, also known as the Y-box, for OCD. And in a 2015 review of anterior capsulotomy, while there's only essentially level 3 or 4 evidence in the literature, it consistently demonstrates a clinically significant benefit. Next slide. The efficacy of cingulotomy was looked at by Samir Sheth in 2013, looking at 64 patients in the MGH cohort. And what they noted was that 35% of the patients had a full response, which was essentially defined again by the field standard greater than 35% Y-box reduction at 1 year. And that at 5 years, essentially, it was a 47% reduction. However, what they happened to note was that at least half of these patients required a second lesion, either a second cingulotomy or a subcaudate tractotomy to be added to this lesional approach. Next. In terms of comparing cingulotomy to capsulotomy in the modern era, Samir Sheff actually also in 2016 published a review of cingulotomy versus anterior capsulotomy. And with a 1-year follow-up, there was an average reduction of the Y-box score of 37% for cingulotomy and 55% for capsulotomy. The average full response rate of 41% for cingulotomy and 54% for capsulotomy. So again, remember, Y-box reduction of greater than 35% is a responder. So there's a little bit of what appears to be a more efficacious treatment for capsulotomy as far as OCD is concerned. Next slide. Enter in neuromodulation. So modern DBS for OCD, and indeed the use of DBS for psychiatric, in fact, the use of DBS for psychiatric disorders and the modern interest in psychiatric surgery again was essentially kindled by Bart Nutan's group in 1999, first published in The Lancet, as you can see here, applying DBS in the classic anterior limb target. And what they found with bilateral implantation, 4 patients in this initial cohort, 3 gaining benefit of at least 35% in the Y-box scores. And that really began essentially, as I said, the modern psychiatric surgery era utilizing DBS. Once again, here we have a midline picture of all of the sort of targets that have been used for DBS for OCD. And again, not all of these are quite in the same plane, but they relatively are. And once again, we see them clustering around that cingulum bundle area. Next. Couple of meta-analyses of the DBS for OCD. This is a meta-analysis of 31 studies looking at DBS to the anterior limb of the capsule, the ventral capsule, ventral striatum, the nucleus accumbens, the ventral caudate, and the subthalamic nucleus. Overall, what they have found was a 45% reduction in Y-box scores across the population of patients getting this procedure. In terms of a response rate, which is probably the best way to sort of, when counseling a patient, they want to know, gee, doc, what's my chance of getting better? And so, you know, generally speaking, a responder rate, and again, response being defined as a 35% reduction in Y-box scores, is approximately 60%. What this study happened to show was that there was no significant efficacy difference between the targets. Not particularly surprising, we see the same thing with STN versus GPI. While there are subtle differences between the two target, overall efficacy rates are the same. Why? Because they're all part of the same circuit. Next. Here's a paper looking at direct comparisons between DBS versus lesions. This is a 2015 review, 20 studies, 170 patients. In terms of DBS, and they kind of looked at mostly anterior limb and ventral capsule, ventral striatum, there was an overall 50% responder rate, and in capsulotomy, approximately a 67% responder rate. Now, again, it's important to understand that the patients undergoing DBS had far higher Y-box scores. Some of the capsulotomy patients were from the era where there was no Y-box, etc. So much sicker patients typically in this cohort for the DBS patients. Only one study to date, period, throughout the entire literature has given class 1 evidence for efficacy of either psychiatric, either lesions or DBS. And that happens to be a French study of the DBS to the subthalamic nucleus for obsessive compulsive disorder published in 2008 with a 68% reduction in Y-box scores. Next. Now, if you look at the literature, all of these targets are sort of have different terminologies: anterior limb of the internal capsule, ventral capsule / ventral striatum, nucleus accumbens. Some also look at the bed nucleus of the stria terminalis, which is a sort of a medial portion of the nucleus accumbens region. But they're essentially all the same target. they, as you can see here, these are coronal views of various different anterior to posterior slices through this region. And you can see essentially what is nucleus accumbens, which is anterior capsule, what is caudate. They're all slightly different trajectory areas. But essentially what you're beginning to see is that there is a extreme heterogeneity of the tissue being stimulated in these regions in humans. Essentially, you know, when you look at basal ganglia targets, or if you look at brainstem targets, the variability from individual to individual is quite small. As you get in front of the anterior commissure, these prefrontal structures begin to have a great degree of variability from individual to individual, which makes targeting kind of tricky based on just a pure gray-white anatomy standpoint. So this is where technology, next slide, like tractography, which can begin to sort of resolve a level of anatomy that is more individualistic from patient to patient, that can demonstrate fiber patterns that may be common from patient to patient, that may result in DBS efficacy. This is an example of a paper looking at this that represents a common frontal thalamic fibrobundle between the STN and the anterior capsule that resulted in OCD treatment efficacy. Other work by Martin Fagui and others in Amsterdam have looked at two fiber bundles within the anterior capsule, laterally something related to what is classically known as the median forebrain bundle, although there's some controversy with regards to that. And then medially of the anterior thalamic radiation, and that they found that the medial forebrain bundle, the lateral bundle, is more important for OCD efficacy. Next slide. So if you look at the drawbacks versus advantages between DBS and ablation, in terms of the drawbacks, DBS, obviously, it's a hardware implant. It's a permanent implant that has to come into the body, and with all the infection and lead breakage and erosion through the skin, plus battery replacement, that is a costly thing. In terms of ablation, well, you can't program a hole. So if the lesion is off target, and believe you me that in real world use, when people make lesions, there's quite a bit of variability in targeting. And there are no salvage options with a lesion. If you make a lesion and there are side effects, you get to live with that like luggage for the rest of your life. In terms of advantages, the DBS, well, as I said, there's their ability to adjust the stimulation to a patient-specific need. And if a patient doesn't want it anymore, it's essentially reversible and removable. And this essentially allows us and gives us an opportunity for more finely targeted, tuned neuromodulation of these circuits. Ablation, there is essentially no hardware, so it's cheaper, and that can be potentially an advantage, especially in areas of the world where resources are limited. Let's put it that way. Next slide. So, you know, in conclusion, you know, and this is an opinion, I hope I gave you the bare facts and you can sort of take from that as you will. There obviously appears to be quite a bit of efficacy on both sides of lesioning and neuromodulation, and this is not the same case that we have in movement disorders, of course, but the truth of the matter is that there is a history of psychiatric surgery that is fraught with a lot of politics and the public perception of intervening in something that is very, very personal. And I think that the neuromodulation, with its ability to be essentially reversible, its ability to be programmed, its ability to be more finely targeted, I think is the more appropriate step where the field will go in the future. Lesions recently have had a bit of a resurgence with focused ultrasound and so forth. But again, my opinion, I think that making lesions in the brain, especially in a first world situation that we're in here, is a philosophical step backwards. So I'm fully in favor of of the advantages of neuromodulation over lesions. And that's it. Thanks very much.
All right, we'll take one or two questions.
Yeah, I'll take a couple questions because I do have to jump off. But from Max, hold on, I can't read the whole thing. Max says, since the only level 1 evidence for OCD is STN and the effect size was so large, is that what you'd recommend? It's hard for me to recommend agreeable that it is the only class 1 evidence. And yes, the effect size was so large, but it's 8 patients, while the total literature of reported essentially ventral capsule, anterior limb of the capsule, et cetera, is in approaching probably 150 to 200 patients. So I think that the burden of evidence is actually far greater on the anterior limb of the internal capsule right now. I do feel, however, that the STN should be looked at more as a target in general. And I think that one of the nice things about the STN, because it's so small, there is an opportunity to tune it limbically and as well as motorically. Any other questions?
Okay, very good.
Great, thanks guys.
Thank you, Brian, appreciate it. Thanks for your time.
Thanks, Brian.
Next,
Take care, guys.
so we'll do the next talk. Let me load it up right here. Okay. So the next talk is Dr. McCann. So you are on, sir.
Okay, so next slide. In the next 15 minutes or so, I'm going to take a whirlwind through where we stand with epilepsy surgery, kind of the opposite of what Brian was saying. This is now predominantly still a lesional field, although obviously there's more movement towards modulation. A lot of this is going to be opinion because there's a lot of differences at different centers of what people are doing, and there's very little absolute evidence. There's just a lot of individual experience. So just to summarize for all the trainees who are on the call, as everybody knows, we do very well for temporal lobe epilepsy and for lesional epilepsy in the 70–80% seizure freedom. As soon as you move out of the temporal lobe and as soon as you move to extratemporal non-lesional, we do worse and worse. And in fact, you'd have to say for some of the things we do, should we absolutely be doing it given our seizure freedom rate? So we have to find ways to do better. Next slide. So if you talk about a treatment gap, the gap is basically many patients are not referred to epilepsy centers because of the fact that they're felt to be too invasive or too dangerous in what we do. And once you get there, a lot of patients decide that they don't want surgery because also they think it's too invasive or too dangerous. Next slide. So when we talk about epilepsy surgery, our primary goal is obviously balancing seizure freedom with minimizing risk. Next. So what that means for the patient next is that we have to think about in temporal lobe epilepsy, patients want it less invasive and safer, and extratemporally, because we don't do that well, we need to be less invasive, safer, and more effective. Next. So what are our current surgical resection indications? Well, if you're at a center that doesn't do a lot of laser, most LITT stands for low-grade epilepsy-associated tumors. So most of those are going to be surgical cases, focal cortical dysplasias, particularly the more extensive ones, cavernous malformations, mesial temporal sclerosis, medial temporal epilepsy. Those are all different lesional epilepsies that we generally do surgery for, although a lot of those are now being invaded into the laser space in places that do a lot of laser. If somebody has mesial temporal lobe epilepsy and does not have a laser, that's an open surgical case. Non-MTS temporal lobe epilepsy, particularly if you don't have some kind of invasive monitoring localizing to a mesial onset. And almost all extratemporal non-lesional epilepsy is still open surgery. Hemispherotomies and hemispherectomies are still open surgery, large topectomies, lobectomies. But again, people are trying to push the boundaries on that. Whether or not there'll be a role for minimally invasive ablation in a lot of these remains to be seen. Next. So if we look at temporal lobectomy. So over time, from larger temporal lobectomy, there's a whole bunch of different approaches people have tried, transsylvian, transsulcal, subtemporal approaches to get to the mesial temporal lobe. But at the end of the day, this hasn't changed more patients wanting to come for surgery. Next. When Gamma Knife first came out, the initial preliminary trial was quite encouraging, but the more recent Rose trial showed that in that randomized trial, it was stopped for difficulty enrolling, that in the patients who were enrolled, that Gamma Knife did not do nearly as well as open surgery. That's not to say there's no role. There's a lot of Gamma Knife being used in Europe still, and particularly if you have an older, unhealthy patient who's not a good anesthetic candidate, it's perfectly reasonable to think about Gamma Knife for mesial temporal onset epilepsy. Next. The real change in this space has been laser thermal therapy. So as everybody on this probably knows, it's stereotactic implantation of an optical fiber. Just keep rolling down these. It's laser fiber in a cooling catheter. It has a very tight margin of actual thermal damage. Keep going. And so really a sub-millimeter boundary of thermal destruction of tissue. And it also allows us in real-time MRI to monitor the thermometry and the irreversible damage zone prediction as shown here. Next. So to summarize all of the last 7 years of work around the country, if you look at temporal lobectomy or selective amygdalohippocampectomy and you compare it to LITT, the laser ablation is definitely less invasive, shorter procedure time, no ICU stay, one to a half a day of operative time, earlier return to work, but the patients do not do as well overall in terms of seizure freedom. There is also obviously not having a craniotomy. So if you have a patient who you know is only going to come for one surgery and you only have one crack at them, then you probably want to do an open procedure. Whereas if it's a patient who's willing to go through a minimally invasive procedure and they're not then seizure free, then that patient it makes sense to do laser ablation on. And that's most of the patients we now see. Next. The LITT works for temporal lobe surgery, but not as well as open surgery. Next. It is safe. Whether it's absolutely cost effective it depends on your hospital and what kind of deal you can get on the add-ons, because it's about $20,000 for a laser kit. A lot of patients are unwilling to undergo open surgery, but are willing to undergo laser. As I said, in our practice now, it's mostly a first-line treatment option for patients. And if they're not seizure-free, some will even do twice, or else we'll do an open resection at that point. Next. Works well in MRI normal mesial temporal epilepsy if you localize the seizures by stereo EEG first. There is an ongoing prospective trial. It's a Medtronic-sponsored trial to further optimize ablation volume targets and patient selection. Next. It's also laser ablation, as I mentioned a minute ago, is being used for hypothalamic hamartoma, cortical dysplasia, low-grade gliomas, and other low-grade epilepsy-associated tumors, cavernous malformation, TSC, corpus callosotomy. So anywhere you can imagine making a focal lesion or disconnection in the brain, people are pushing the laser boundaries. But as in all of these new technologies, what we really need is we need data and we need time. Because most of these things, most of these series are 1 year or now maximum 2-year follow-up, compared to open surgical series where we now have 10, 15, 20 years of follow-up. We know in open surgery that we lose seizure outcomes over time. How much they're going to drop off with laser is going to largely determine in a lot of ways how much this sticks around for various pathologies. Next. Next slide. Next, yep. So patients, though, want minimally invasive. If you look at a grid operation versus the stereo EEG operation, it's not even close, particularly in the pediatric population with kids, but also the adult population. You can just scroll down the other text in here. So, patients generally want to try LITT over an anterior temporal lobectomy or a selective amygdalohippocampectomy. They prefer stereo EEG if it's reasonable over subdural grids and strips. And they want to know whether or not patients will walk into your office with a multilobar cortical dysplasia and say, why can't I get laser? because they go on the internet, they realize how minimally invasive it is, and our job is to make sure that we're expanding indications in appropriate fashion, but not doing things that don't make sense just because we have the technology. Next. So what about neuromodulation? Well, it fits in the gap between open resection and medical therapy in that it's got a much lower chance of seizure freedom, but also a significantly lower risk of side effects or complications because we're not ablating or resecting. Next. And when we talk about DBS versus RNS, it's actually a narrowing gap because while DBS has traditionally been open loop stimulation of a node or a pathway in a network, and RNS has traditionally and is now closed loop stimulation of a focal epileptogenic zone. Next, you can keep marching down. What we see over time is that there's more and more application of DBS in various closed loop fashions, at least experimentally, while RNS is more being applied to network pathways and nodes. So in fact, there's kind of a merging at the middle of the two technologies based on people who are now practically using them. Next. So as everybody knows probably on the call, RNS has been around for a while and it's gone through 2 trials. The goal is to put an electrode on or in an area of seizure onsets, 1 to 2 epileptogenic zones, and then to stimulate. Next. And so what we see is it's well tolerated and generally safe. 10 to 15% of patients can be seizure free over time. And the longer it's in the brain, it seems like the better it does in terms of % reduction in seizures. Next. So most RNS systems being put in, first off, it's only FDA approved for adults at this point in time, only approved for 1 to 2 seizure foci. Patients commonly treated are mesial temporal lobe patients who have bilateral seizure onsets or unilateral, particularly dominant seizure onsets with a functioning hippocampus, eloquent cortical areas that we don't want to resect, some areas of deep lesions such as periventricular nodular heterotopias, although these are also being approached with laser ablation, difficult to reach or difficult to resect areas people are trying RNS on, and patients who have had a suboptimal response to prior resection and or VNS. Next. So go ahead, next. So basically, the other question we want to be knowing is, can we use stimulation to increase the number of candidates who become potentially seizure-free? Next. So one of the ways this has been looked at is if you look at patients who have had bilateral mesial temporal RNS systems implanted for bitemporal epilepsy. Next. So this is a poster that Larry Hirsch at Yale had at the AES of patients who subsequently underwent a resective or ablative procedure on one side after it was demonstrated that a predominance of seizures were coming from that one side, while the other side continued to be stimulated with the RNS. Next. And when you take that approach, you find that actually over time, 70% of patients were actually rendered seizure-free with a fairly respectable follow-up time. So these are situations where using an RNS, not just to get seizure control, but also as a diagnostic tool to provide another therapeutic option over time to patients with bitemporal epilepsy. Next. So go ahead, next. So there'll be more and more ways that people are going to be figuring out how to use neuromodulation, not just when surgical resection or ablation is not a primary option, but also to figure out, can we find better ways to neuromodulate in the brain to potentially make safer approaches? So particularly, as I mentioned, non-MTS mesial temporal lobe, particularly dominant hemisphere. These are very high-risk patients for neurocognitive decline. MRI negative epilepsies where there may be a very subtle focal cortical dysplasia somewhere. And again, our goal is seizure freedom, but as Howie Weiner's shown so well in the TSC group, you can still make huge differences in patients' quality of life with large degrees of palliation, with improvements in patients' quality of life, even if you don't always make them seizure free. So our goal still has to be balancing risk and benefit. And we'll probably see, as we get better with neuromodulation, understand it more and understand how to stimulate, when to stimulate. Things like focal cooling may come into play, or focal drug delivery. We'll probably be seeing increases in epilepsy neuromodulation, particularly in risky parts of the brain. Next. So here's a quick 30-second case of a patient illustrating how things have changed. This is a very high-functioning 35-year-old female, right temporal seizures, MRI normal with just a choroidal fissure cyst. And again, the patient who is functioning professionally at a very high level. In the past, we might say, well, we're not sure if it's mesial or lateral in this situation. You could have argued, and in fact, when I started in practice 20 years ago, this patient would have either had a subdural grid or a non-dominant temporal lobectomy. Next. So the PET was hypometabolic throughout the temporal lobe. Next. So again, multiple choices of what you could do here. So this is a patient who underwent stereo EEG about 5 years ago. Next. So here's the very simple stereo EEG implant. Next. With very focal, so this is the implant. Next. Very focal seizure onsets in the hippocampal head and body. Next. So, and then next, this patient ended up with a non-dominant laser ablation, is 4 years seizure-free and never had her head opened in any fashion, where in the past she would have had at least 1 and probably 2 craniotomies of some sort. So this is one of the reasons why patients are so interested, because minimizing neuropsychological deficits from resecting a lot of unnecessary brain, combined with minimizing the morbidity of open surgeries. Next. But what would you do if this was coming from the dominant hippocampus? A high-functioning individual, a normal dominant hippocampus, if you went through a stereo EEG and proved that there were hippocampal onset seizures, this would be a very high-risk patient in terms of taking a neuropsychological hit, who probably would not be very happy with you for it. So this is a patient who, at least in our hands, we would definitely start with NeuroPacing and see how well it works. So again, same situation. You could make an argument for open resection, for laser ablation, or for RNS, depending on the exact scenario, side of the brain, and neuropsychological status of the patient. Next. So one of our holy grails is going to be figuring out how do we see difficult to see lesions in the brain that we have trouble picking up with the human eye. So there's going to be more and more computer-based programs to make subtle things more visible, so we can find subtle areas of dysplasia to localize things in parts of the brain where we're not very good at it right now. And hopefully over time, we'll be doing less and less invasive monitoring, so we can jump to things like laser ablation or neuromodulation, bypassing the invasive monitoring step. Next. So overall, in conclusion, in the last 5 to 10 years, epilepsy surgery is one of the most rapidly changing areas in neurosurgery. Advanced imaging combined with minimally invasive techniques are making things safer overall, but the long-term benefit of these approaches absolutely needs to be demonstrated. And I would say both laser ablation and responsive neurostimulation and any form of closed-loop neuromodulation are absolutely in their infancy. One of our biggest challenges is to non-invasively detect the epileptogenic zone interictally. This is likely going to come through advances in neuroimaging. And there's a lot of other new techniques coming. As I said, machine learning of MRI for epileptic zone detection with a number of techniques, robotic ablations that'll be automated, use of focused ultrasound, less invasive, and new paradigms for responsive neurostimulation. So we're going to see in the next 10 years, like epilepsy surgery has changed in the last 10 years, that there's going to be a whole novel approach to how we're doing things. Thank you very much.
Great.
Question?
Thank you. We'll take one or two questions.
So there's a question from Max at UCSF. What's the experience like operating on post-LITT patients? So my experience in post-LITT is, although it looks like it should be easier when you see a nice hole where the hippocampus was, that in fact the anatomy is a lot more complicated. Because you've ablated the hippocampus, a lot of times the hippocampal scar within the ablation is scarred against the choroid plexus, and sorting out the safe anatomy, sorting out the choroid plexus, the choroidal point, what's safe, what's not. The peel boundaries will be intact medially, but the hard part is sorting out all of the relevant intraventricular anatomy that normally guides your resection. So I would say I've only done about 5 of them, but so far I've found that actually it takes longer and you have to be more careful because of the alterations both in vascular anatomy, risk to things like the anterior choroidal, and making sure that you really identify your interventricular anatomy relative to the choroidal point, choroid plexus, all the safety boundaries that we normally use for mesial temporal epilepsy.
We'll take one more question.
Yeah, from Dishad. What are your thoughts on when to recommend anterior nucleus of the thalamus versus RNS? So, you know, it's obviously a developing field. DBS of the anterior nucleus, while it's been around in Europe for a few years, as it was only just approved last year here in the States. So I think there's a growing but unclear experience. For me personally, if I know that there's a focal onset that I can identify, I'm generally going to try RNS first, versus if you think it's more multifocal or a larger part of a network that you want to interrupt. But again, people are working different boundaries on this. I mean, the people I know at the Mayo Group in particular has been figuring out kind of unique configurations and hardware to do different aspects of stimulation in the brain. So it's very much a shifting baseline. I think as long as what you're doing is A, justified, B, agreed upon by your neurologist, and C, safe, then and also the patients understand that, you know, that we don't have huge amounts of data on some of this, then I think there's no absolute data. I mean, you look at the 2 trials, anterior nucleus DBS and RNS, while they were different trials in terms of the patient population, the data are superimposable. So the therapies, at least for global treatment, work very similarly. Whether over time, for instance, RNS is going to be much better for a focal hippocampal onset where it logically makes sense that it should be, it may or may not, we have to see.
Great. All right, we'll go to the next talk.
All right, I'm going to have to duck out.
Thank you, Dr. McCann.
Okay, thanks, guys. Have a good night.
Thank you. Appreciate it. Thank you. Bye-bye. Okay, so let's see. Okay, are you able to see the slides?
Yes, thank you.
Great. All right.
Okay, so my name is Jonathan Miller. I'm at Case Western Reserve University. What I'm talking about tonight is awake versus asleep, deep brain stimulation, and which should you do? So next slide. Okay, some background. So it's worth remembering when talking about how to implant electrodes that neuromodulation for movement disorders originated from therapeutic lesions. And originally these were targeted entirely using ventriculography. Next. If you look at the methods that were used, it's essentially a lateral fluoroscopy view of the brain using either a contrast dye, and you can see the anterior and posterior commissures, which are sort of landmarks that we still use to this day to identify where our various targets are. But this is a relatively inexact method of targeting, and so additional confirmation was necessary. It's interesting that if you look at the targets that were used for instance, Parkinsonian tremor in the mid-'80s. Next, if you look at there's a article that was published by Laurie Leighton in 1985, and you can see that there's really a wide variety of ideal targets. This is a survey of all the sort of the who of functional neurosurgery in the 1980s, and it kind of clusters around our current VIM target. You can see it's at the ACPC line and halfway to PC, and kind of at the where you'd more or less expect it to be, but some of them are out of that area. It's relatively inexact science. Next. Today, however, we have MRI techniques that allow direct visualization of these targets, as well as intraoperative verification in the case of intraoperative MRI. And we have the consensus targets for STN, for VIM, and then other targets that have been described, and some of them shown here. So next slide. So next slide. So what's the advantage of awake versus asleep DBS? It's worth remembering the controversy is not about the anesthetic technique. It's not whether it's awake or asleep. It's ultimately a question of how we're going to accurate lead placement before we're finished with the case. And the goal for either one of these is to correct for targeting error, and that includes spatial inaccuracy, distortion, brain shift, brain deflection. The fact is, no matter how good your stereotactic setup is, you're always going to end up with some degree of targeting error. To fix this on the Awake DBS side, you're using mapping or microelectrode recording in order to identify very precisely the physiologic signatures of where you are. Next, in the case of a sleep DBS, essentially what you're using is a different technique, often intraoperative imaging, using either MRI or CT scan co-registered to an MRI to verify that the targeting error, the spatial inaccuracy, and all the things that lead to that have been compensated for. So if you can scroll down through these. So the advantages of Awake DBS, the mapping is you have a physiologic target. It's a functional target. It's a target we're actually targeting. Spatial accuracy in the case of microelectrode recording is extremely high, in the order of much less than a millimeter. Awake DBS works even when an MRI is not available. If it's just a pacemaker or suboptimal, remember this was available and very successful even in the ventriculography era. Next, it allows you to test drive the stimulation to confirm that there's good therapeutic effects and the lack of side effects. Next. It's an excellent research tool. You can identify physiologic signatures of both the disease under study as well as the effects of treatment, which can be very helpful. Next. And I'll talk a little bit about this. Over the long term, there are fewer off-target effects, and that may affect the durability of the therapy. Although that whether or not that makes a difference is controversial. As far as the sleep DBS is concerned, this is intraoperative imaging. So now we're looking at an anatomic or structural target as opposed to a physiologic target. Next. It is lower risk in terms of hemorrhage, edema, and cognitive decline, and there's very good data for this, which I'll talk about in a minute. There is lower operative time, lower complexity, cost is less, there's less CSF loss, which leads to less pneumocephalus, and significantly less patient discomfort because they're asleep. They're not awake, they're not off their medications, they don't have to cooperate. There's some data that there's better speech outcome, particularly in terms of phonemic and category fluency, likely related to the fact that there's fewer penetrations of the brain. Next. The targets that are least tolerant of misplacement are also the most visible on MRI. The VI thalamus, for instance, which is not visible at all, is fairly forgiving as a target, whereas the STN GPI is very clear on MRI. So those tend to lend themselves to intraoperative imaging. Next. And finally, the stimulation volume, the which you're actually creating, is fairly large and is defined empirically anyway during programming. So being in precisely the right place, although there's always a premium on accuracy, you're ultimately this is a closed loop programming process. You're going to control the program based on the therapeutic effects and side effects. So being in the right place is important, but 0.1 millimeters may be excessive. So slide. So first, so you could say, well, why would you not just verify it? I mean, it's more uncomfortable, maybe more expensive, but at least you know you're in the right place. And I will say the reason, the mitigating factor there really is surgical risk. And so there's a number of studies that have shown that there is risk associated with mapping, particularly microelectrode recording. You can scroll through these. An example is shown here. Most of these pallidotomies literature, but comparing some of them with and without MER, significantly higher risk of postoperative weakness, dysphagia, hemorrhage, particularly hemorrhage, adverse effects such as stroke. The DBS for PD study group, New England Journal, showed the number of passes was strongly correlated with hemorrhage, 4.1% in cases with hemorrhage, in cases with hemorrhage versus 2.9 in cases without hemorrhage, although they didn't show a statistically significant difference other than that. This bottom study, you can see that when MER is not used, hemorrhage rate is generally significantly less. Next slide. So there are risks of mapping. And the clinical results are similar using either technique. The idea of using image-guided DBS is, although it does not have the benefit of physiologic targeting, you can see initially with the MER using various, MRI using various platforms, and then later CT scans show similar decreases in UPDRS that we see with the classic techniques, similar error, and importantly, no hemorrhage or pneumocephalus that we typically see epilepsy. You can see here from a number of levodopa is similar, similar results for dystonia, and hemorrhage, cognitive mood decline is also, and you can see the therapeutic window and UPDRS scores are identical. This final study here, you see the asleep had, and I'll talk about this study in a second, had better motor outcome, better speech outcome, better quality of life. Again, none of these are randomized compared trials, so it's not possible to say precisely which is better. The important point, either one of them can give you very good results. Next slide. So what about comparison? Any direct comparisons? Well, there aren't any direct comparisons of awake versus asleep. The study I mentioned, the Brodsky study from 2017 out of OHSU, compared their retrospective series, found that there were similar outcomes in UPDRS2, UPDRS. Overall, slightly better motor outcomes for the asleep, and speech outcomes were slightly better, which led in an editorial for that article to say that confirmation of electrode placement before the procedure is finished is absolutely essential. The method of confirmation may be less important, and the author's editorial went much farther than that and said that MER essentially should be used only as a research tool. A very large meta-analysis next. Comparing the various studies that have been published, 145 studies, 8,000 patients, this is out of San Francisco, Stanford, found that there was a statistically significant increase in the risks of intracranial hemorrhage and infection when awake anesthesia was used with mapping. There was also a significant increase in off-target side effects. So, of course, to boil that down, what that seems to indicate is that what you're trading a lower of complications, and that's what you gain, and what you lose is a slightly lower therapeutic range. Your off-target effects are a little bit higher, and that gives you less programming flexibility over the years, and could potentially lead to less durability over time. Although that has not been shown. It's a theoretical difference. Either way, though, it is very clear from all of this data there is no significant difference in clinical motor outcomes. Regardless of what you do, you're going to, as long as you're doing it the right way and getting the lead in the right place, regardless of whether you're using imaging with a sleep placement or whether you're using awake with microelectrode recording and intraoperative confirmation, it's still possible to get very good motor outcomes over the long term. Next slide. So to answer your question, what should you do? Well, first of all, experience and equipment is important. If you have equipment and experience with microelectrode physiology, that tends to push towards the awake side. Intraoperative imaging towards the asleep. And this isn't trivial. The imaging you have to have intraoperatively in order to be able to accurately image the lead makes a big difference. There are MRI platforms that make it possible to target using MRI directly. It's also possible to use intraoperative CT scan, or even some of the intraoperative spinal imaging, such as the O-arm, which is how it. Although you have to recognize that that's not as it's particularly with some of the CT scan related or X-ray related or based technology, tissue contrast is not as good as it is with MRI. Secondly, is the MRI available, or in the case of the pacemaker, if it's not, or is the target visible on MRI? If not, awake and it may be better. If is, then asleep. Obviously, if you have a very high quality MRI with a visible target, and then the asleep DBS becomes easier. Next. Is the patient able to handle awake anesthesia? Some patients just can't. This includes patients who have significant movement disorders that make it difficult, or patients who have severe claustrophobia. That may indicate that awake anesthesia is more appropriate. Next, or sleep anesthesia is more appropriate. And then finally, research applications. There are microelectrode recording and test stimulation can have profound applications for research. It's possible using these technologies to get tremendous physiological insight into what the brain is happening at the level of single units, as well as local field potentials. And there's an awake patient really get the maximum information from that. So next slide. So in conclusion, Both Awake and Asleep DBS are associated with excellent outcomes. And I think the most important thing to recognize, there really is no evidence that one is unequivocally better than the other. Regardless of what you do, as long as you confirm that the lead is in the right place using some sort of confirmation beyond simply the stereotactic targeting platform, you can still get excellent outcomes with with any of the targets for any of the disorders for which these are used. Awake DBS is associated with much greater accuracy and the ability to test drive your lead. You can look for efficacy and side effects. And there is a very strong trend towards fewer off-target effects due possibly to the increased precision, which may increase durability over time, although that has not been shown to be true. It's a theoretical advantage. Sleep DBS, on the other hand, is associated with significantly less complications, particularly hemorrhage, but also edema, pneumocephalus. There's less patient discomfort, less complexity, less cost, and significantly lower operative risk overall. So there are advantages and disadvantages to each technique, but there really is no evidence that either is truly superior to the other. So it sort of depends on the situation. And in some cases, it may even depend on the patient. But both of these are associated with excellent outcomes as long as the leads are placed in the correct way, using the neurosurgical principles that functional neurosurgeons are trained to do. Thank you very much.
Awesome. Thank you so much. We'll take questions.
Yeah, so the question here from Max, for Asleep DBS, intraoperative CT merged with pre-op MRI versus intraop MRI. So we've done it both ways, and I don't think there's much of a difference personally. We actually have tried intraop CT as well as intraoperative O-arm, and I don't think there's much of a difference. The fusion algorithms that are available today are really spectacular. So in prior years, there were frequently co-registration problems. That doesn't really happen anymore. One of the concerns about using, for instance, O-arm or these spinal imaging systems, which are used for this, they're not true CT quality. So you have to make sure that you are able to see what you can see on those, because they pretty much can only visualize bone. MRI also is prone to distortion, which can make a difference in terms of targeting. MRI, the one advantage is that you really do see exactly where you can actually see the tissue around your lead. So that may be a theoretical advantage. I think in practical terms, there really is no difference. My personal results, we've done over 100 cases now with asleep anesthesia, and we've compared that to the 400 cases done with awake anesthesia. We found no difference at all in outcome in terms of motor response for any of the things that we treat. And we also haven't seen a difference when using MRI, intraop MRI, intraop CT, or intraoperative multiplanar X-ray that's fused then to the preoperative MRI. So I don't think there's a significant difference in accuracy or in outcome.
Great. One more question. All right. I guess this brings us to the conclusion of the webinar. Again, thank you to the mentors for their time for this webinar, and thank you all for attending.
Thank you.